Ladies and gentlemen, it's my great honor and privilege to welcome everybody here for this Revolution Heart Failure Educational Program. This is the first webinar in this series. And together with me, my name is Ewa Jankowska, I work with Wrocław Medical University. There is a group of excellent experts in the field of heart failure. Professor Andrew Coates will join us later. We also have Shelley Zirut, Lars Lund, Michel Komaida, Martin Cowie, Yui Zhang, and Peter Liu. As you can see, we have excellent experts coming from all over the world. Today we will be discussing real-world heart failure evidence where we are regarding the epidemiology and treatment of patients with heart failure, trying to identify the gaps. And during the second part of this webinar, we will present you the results of the two surveys that have been executed among physicians and patients to trying to identify the educational needs and gaps. So without further ado, I would like to invite Shelley Zirut, Lars Lund, and Michel Komaida, who will discuss the real-world heart failure management global overview.
Welcome to Real-World Heart Failure Management, a global overview. I'm Shelley Zirut from Winnipeg, Canada, and I'm going to speak to you about the new universal definition and classification of heart failure. These are my disclosures. Well, the universal definition and classification of heart failure was a joint endeavor by the Heart Failure Society of America, the ESC Heart Failure Association, and the Japanese Heart Failure Society. I'm proud to say that the Canadian Heart Failure Society also endorsed this, and this was an important consensus document to provide a simple, clinically relevant, and conceptual comprehensive definition of heart failure. And it was chaired by the masterful Professor Beacom Boskert, along with Andrew Coates and Professor Tsusui. This is the universal definition and classification of heart failure. It requires symptoms and/or signs of heart failure caused by structural and/or functional cardiac abnormalities, including valvular heart disease and LVH, for example. And it must be corroborated by at least one of the following, including elevated natriuretic peptide levels or objective evidence of cardiogenic, pulmonary, or systemic congestion. And you can see them defined on the left-hand side of this panel as well. These are the new heart failure stages, including stage A, those individuals at risk for heart failure. And this would include people with hypertension, diabetes, obesity, cardiovascular disease, exposure to cardiotoxins, and a family history of heart failure as well. Then we progress to stage B, those individuals without symptoms, but evidence of structural heart disease. Stage C, we see in many of our heart failure clinics, those individuals with symptomatic heart failure. And then finally, stage D, those individuals with the most severe refractory symptoms related to heart failure. And I think this is an important element of the new universal definition, the classification by left ventricular ejection fraction. We're all very familiar with HFrEF being defined as an ejection fraction less than or equal to 40%. Mildly reduced ejection fraction is getting a lot of attention these days and is defined as those individuals with an ejection fraction between 41 and 49%. HFpEF with an ejection fraction of greater than or equal to 50%. And then heart failure with improved ejection fraction, something that we strive for in all of our HFrEF patients, is defined as those individuals with an ejection fraction at baseline of less than 40%, who then have a sustained 10-point increase from baseline in their ejection fraction on a second measurement. And with that, I'm going to turn it over to Professor Lund, who will be speaking to you about global epidemiology and the burden of heart failure.